Hello, everyone, and thank you for joining us for today's webinar. We will be learning about RHC coding and documentation. The webinar today is being recorded and will be posted to our website. We will also send the recording and the slides to all participants at the end of the series. My name is Latrell Courtney, and I am the Clinic Consultation Specialist with the National Rural Health Resource Center, which is providing this webinar today. This webinar series qualifies for ACHE credit. Caleb Lazinski will be sending out an email after the final installment in the series with a link to receive credit. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located on the bottom ribbon of the middle of the screen. If you haven't already, please make sure to take a moment to type your name, title, and organization in the chat box so we know who is joining us today. This helps us get a good feel of the audience on the webinar. The National Rural Health Center is a non-profit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about our commitment on our website. Please join us for these upcoming webinars. On August the 17th at 11 a.m. Central Time, we will have the FQHC Coding and Documentation webinar series. On August the 24th at 11 a.m. Central, we will have HCC Risk Adjustment Update. And then on August the 31st at 11 a.m. Central Time, we will have Telehealth Insights post-PHE. Before I introduce our speakers, Caleb Lazinski will be pulling up the polling questions. The polling questions are rated on a confidence scale and help us measure knowledge gained on today's webinar. Caleb, please pull up the polling questions. Now we'll introduce today's speakers. We have Caroline Goldman Hernandez. She is a senior consultant of Forvis Healthcare Performance Improvement. She has 5 years of experience in coding compliance, denials, and revenue cycle. Caroline began her career with a large clinical staffing and revenue cycle management company where she obtained experience in claims processing, process improvement, data analysis, ICD-10 coding, AMA, HCPCS, CPT coding, insurance provider rules and regulations, and revenue cycle procedures. We also have Stacy Gee. She's a member of Forvis Healthcare Performance Advisory Services Division and focuses on hospital revenue cycle services. Stacy is an experienced healthcare consultant with many years of experience in assisting the operational and financial performance of healthcare facilities. Her past role as a department manager in a healthcare organization helps her identify and relate to the daily challenges presented to clients. She has experience in building skilled nursing facility services as well as long-term care services. I will now pass it over to our presenters.
Thank you very much. We appreciate that. And thank you guys for joining. I'm Stacy Gee. I'm going to kick things off and just full disclosure, I'm probably going to drop off the video because my laptop has been doing something very weird. So, you know, it's that funky, it's doing something funky, that technical IT term. So I probably will stop the video because sometimes it kind of freezes up on me. So, but I will still be here. I'll be the one presenting. And then I think one of the things that I want to share is, you know, if you guys have any questions or, you know, something comes to mind as we're going through this material, drop questions into chat, or, feel free to ask questions and comments or anything as we kind of go through this. So we will get started. You guys can see my screen? Okay, perfect. Okay, let's see here. All right. So today we're really going to take this hour that we've got, and we're going to kind of cover the basics of RHC billing guidelines, coding and documentation guidelines. We're going to touch a little bit on diagnosis coding. So we're just going to kind of, we're going to dip our toes into just kind of almost all of the aspects related to RHC billing. So we've done the introductions. This is the agenda. We're going to talk about what is an RHC, the claim billing differences, services provided, reimbursement. And then if we have any questions, which we would hope that we'll have some questions at the end. These are this is myself and Caroline. Okay, so let me move this over here. So you guys should just be able to see the full screen. Is that true, Caroline? Okay, just wanted to make sure. All right, so what is an RHC? So an RHC is certified to receive special reimbursement from the Medicare and Medicaid programs. There are some very specific reimbursement payment methodologies that apply to RHCs. The purpose of an RHC is to provide or improve patient access to primary care, primarily in those underserved rural areas. Clinics that are designated as an RHC are reimbursed on a couple of different methodologies. One of them is the AIR, which is your all-inclusive rate. This is how you're paid for your Medicare encounters and visits. And then probably for some of your Medicaid, you're going to be paid on the PPS, which is the prospective payment system for Medicaid, and probably even some of your commercial payers. And then some of those other commercial payers have their own payment methodologies that may be specific to their payment methodologies. So you kind of got a combination of how you may be reimbursed for those encounters and those visits that take place within an RHC. There is a little bit of enhanced reimbursement if you're designated as an RHC. We'll kind of talk briefly about that. And then there are some very specific location and condition eligibility requirements that must be met to be certified as an RHC. And a couple of those specific conditions are 51% of the services provided in an RHC clinic must be primary care services. So family practice, internal medicine, peds, OB. And then one of the other condition eligibility requirements is the clinic must be staffed at least 50% of the time with a mid-level practitioner. So those are just a couple of examples of some of those eligibility requirements. Let's see here. I'm having to shuffle some things around on my other screen here because I can't get to what I need to get to. There we go. Okay, so there are different types of rural health clinic types. There's a provider-based. This is an RHC that's owned by a hospital.
Hey, Stace, I'm sorry to interrupt. Your slide didn't change.
Oh, it didn't?
No. If you advanced it, I didn't see it on my screen.
Is it changing there?
No, I still see what is an RHC.
Okay, let's see. I'm not sure what to do here. Hold on. Because when I look at it, it looks like it's advancing.
I can, I have it pulled up. I can share if I need to.
Sorry, I don't know. Yeah, as I click through, it's advancing on my end. Sorry about that, guys. I told you my laptop's been doing funky things. Want me to stop sharing?
Yeah, okay. I think I got it. Your share screen is loading. Okay. Can everybody see that now? Different RHC types slide?
Yes, I can see that.
Okay, perfect.
Okay, perfect. Sorry, boy, I don't know what's happening. I'm glad I don't know. That's very odd. Thank you, Caroline, for pointing that out and
Of course.
being able to jump in. So we were just talking about the different RHC types. So there's the provider-based. These are clinics that are owned by a hospital. They are not considered hospital outpatient departments. They are a true clinic setting, not a hospital outpatient department. And the billing for these provider-based RHCs is based on the hospital's EIN, which is the federal tax employer ID number. And then we have independent RHCs. So these refer to those RHCs that are freestanding, truly not associated with any other entity that is truly freestanding. And the billing is based on that particular RHC's EIN number. So just two different types of RHCs that we have out there today. Okay. So who are qualified providers that are eligible to provide services within an RHC? So physicians, MD or a DO, nurse practitioners, physician's assistants, certified nurse midwives, chiropractors, dentist, optometrist, podiatrist. And then we have clinical psychologist, and then licensed clinical social workers. So these are all what CMS or Medicare considers to be qualified RHC providers. And so all of those services need to be rendered within the four walls of that RHC during RHC hours and billed as such. Now, specialists can be integrated into the RHC if you have a need for a specialist. Okay. Next. Oh, you're ahead of me. Sorry. Nope, you're good. So behavioral health providers. So within the RHC world, the providers that CMS, Medicare has identified as eligible behavioral health providers are going to be your clinical psychologist, your licensed clinical social workers, a licensed clinical professional counselor, which is an LCPC, or a clinical professional counselor. Are not payable by Medicare. So check with your own state specific guidance to see if those LCPCs or CPCs are eligible. In most states, we have found that they are not. So just make note that those last two, those LCPCs or the CPCs are not payable by Medicare. And then you should check with your state MAC to see if they are.
It looks like there is a question in the chat. What about LMSWs?
LMSW, those licensed medical social workers, is that what that is? Nurse practitioner with psych, that's a good question as well. I'm writing these questions down so that we can get a good appropriate. Licensed master social worker. Thank you. Okay. I've not seen those on the CMS eligible provider list, but let me do some additional digging on those two for you, for the nurse practitioner with psych and then the LMSW. The list that we had is literally pulled from the CMS guidance. So let me do additional research and see what we can find for you on those two. Good questions. Thank you. Okay, so what does Medicare consider to be RHC locations? So the RHC, obviously, the patient's residence, which may include an assisted living facility, a Medicare covered Part A SNF facility, and then even the scene of an accident. So kind of odd, but based on the Medicare guidelines and what is identified in the Medicare benefit policy manual, these are eligible Medicare RHC locations. So they've identified what is an approved location, and now we're going to talk about what is not an RHC location. So according to Medicare, RHC's visits may never take place in an inpatient or an outpatient department or a hospital, including a critical access hospital, or a facility which has specific requirements that preclude RHC visits. So for example, a Medicare comprehensive outpatient rehab facility, which is also a CORF, what we call a CORF, or a hospice facility. So just very specific locations as identified by Medicare as to what is considered an RHC location versus what is not. Okay, so when we start thinking about the billing side and what does that look like, these are the types of bill types that we would expect to see for rural health clinics. So your type of bill is it's a 4-digit number that tells that payer what type of bill it is. So 0710 means that you're telling that payer that's a non-payment, it's a zero claim, all charges are non-covered. So they're not anticipating any kind of payment or reimbursement. It's truly an informational type claim. 0711, this is going to be your initial claim or your initial type of bill that you submit for your payers. This is your original claim. This is going to be your first original claim. If you make any type of adjustment to the claim, once it's been submitted, then it's going to revise that claim to a 0717, which means that's an adjustment claim. You've made some sort of adjustment, revision, something changed on that claim from the original submitted format or formatted data. And then 0718 is a canceled claim, or that you are canceling that claim altogether. Another note worth mentioning, and this is not just specific to the rural health center, this is across the board for anybody that bills Medicare. The dates of service cannot overlap calendar years. I found that out the hard way many years ago, trying to submit a claim from the end of September through, I don't know, mid-October, something like that. And it denied because in the Medicare world, you could not submit an overlap date from September to October. October 1 is a new year for Medicare. So keep that in mind as you're reporting claims. And then you're going to have split billing periods that overlap calendar years. Again, you're going to have to take that into consideration as you are preparing that claim for submission, just knowing that you've got, you can't submit September charges and October charges on the same claim. It will not overlap like that. Okay, applicable revenue codes. I've just provided a list here of all the revenue codes that Medicare has identified as being applicable revenue codes. The ones probably the most recognizable or familiar is that the 0521, those are going to be your clinic visits that are provided by a qualified RHC provider. And then the 0900, which are your behavioral health type visits. And we're going to talk a little bit more in specific detail on some of these revenue codes. But I just kind of wanted to provide a whole kind of range of those revenue codes that Medicare has said this is kind of what we expect, anticipate and expect to see these revenue codes on rural health care, rural health clinic claims as they come through our system. You'll also see 0636, which is for injections and immunizations. That's pretty common. And then the 0250 for your pharmacy. So this is really just a good reference slide to keep at your fingertips. Okay, so for rural health care, we've got a couple of different things that we have to keep in mind when we're working on our billing. So for Medicare claims, and again, this is all based on if you're an independent rural health clinic or if you are a provider based. So I've kind of broken this down to just kind of show you the differences between the independent versus the provider based. There are some differences on what type of claim you're going to submit based on the type of rural health clinic that you are and what kind of services are you providing. That's going to dictate the type of bill that you're going to submit and who you're going to submit it to. So when you look at this, this is specific to Medicare. So if you're independent and you're submitting a claim to Medicare for your encounter and your visit, you would expect, or that's going to be billed on a Part A UB04 claim. That should really come as no surprise to anyone. And on that claim, you're going to use the Rural Health Clinic's CCN, which is the CMS certification number, the RHC NPI, and then I see a typo there, should be RHC EIN. So that's what you're gonna is going to appear on your UB04. For your CLIA lab services, those are going to be on a Part B 1500 CMS 1500 claim form. And then you can see as you go across the grid here, just kind of what those different services look like. Again, based on if you're an independent or if you are a provider-based RHC. And this slide in particular is specific to Medicare. So if we look at the next slide, it's a little bit different based on your payer type. And again, it's driven by if you're an independent or if you are a provider-based clinic. And you can see the first column is Medicare, really, and as you work your way across this grid, it's really kind of identifying for you by the payer type what that claim form is going to look like or what that claim form is going to include. So again, this is a point of reference for you all. And just understanding which, if you're an independent or you're provider based, this is kind of a nifty little cheat sheet, if you will, for those services that you're providing and what that expectation is, and what's going to go on that claim form based on if it's a Medicare Advantage or if it's a commercial payer, or if you're looking at a Medicaid or a Medicaid MCO. So just kind of a very visual. One other thing on this is the commercial billing is a little bit different because a lot, or I would say most commercial payers don't recognize the RHC status. So that's kind of just kind of a weird little nuance. So because of that, the claim needs to be billed by the provider's NPI number, just as a tidbit on the commercial side of things. Okay, so what services can RHCs provide? So, and what is the definition of an RHC encounter? So it's a medically necessary medical or mental health visit, or it could be a qualified preventive health visit, face-to-face with the physician, a PA, an NP, the certified nurse, midwife, clinical psychologist, or a clinical social worker. So the services can include primary and preventive care services, services and supplies furnished incident to the service. So for example, venipunctures, homebound visiting nurse services, some care management, and new specifically in 2022, transitional care management, and now as well chronic care management. And there's some very specific guidelines around chronic care management. I don't want to say it's fairly new, but a lot of places are not charging for chronic care management services because it's fairly new, but there's some pretty strict documentation guidelines around chronic care management. Your flus, your pneumococcals, COVIDs are 100% covered by Medicare on the cost report. So that's how Medicare is going to gain an understanding of how many and what you've provided in terms of your flus, your pneumococcals, and your COVID. There RHC telehealth visits are allowed, and especially kind of bubbled to the top specifically during the PHE, and there are still some waivers in place post PHE that will be in place until the December 31st of 2024. So some of those waivers have expired, some of them have become permanent, and then some are still temporary. So there are some very specific telehealth requirements and billing guidance post PHE. And then mental health telehealth visits, those were new in 2022, specific to RHCs. I don't think typically in the past those were covered, and beginning in 2022 they were. Okay, so what is considered non-covered? And again, these are Medicare's definitions. So non-covered services are first and foremost your typical Medicare exclusions like routine physicals, dental care, routine eye exam, hearing tests. That's kind of been the way it's been for many, many years. The technical component of RHCs, those are considered non-covered. Lab services, even though we do know that lab services are taking place in the RHC setting, Medicare has deemed that as a non-covered service. Venipuncture is included with your air payment rate, which is your all-inclusive rate when it's furnished in the RHC setting, or it's an incident to the RHC service that was provided. We know that DME, crutches, hospital beds, wheelchairs, all of that, those are non-covered. You really have to be enrolled and signed up as a DME provider to even get reimbursement, which falls outside the RHC eligibility. Ambulance services are non-covered, and then prosthetic devices, which may replace all or part of an internal body organ, and then body braces. So that's what Medicare has deemed as non-covered by RHC services. When we talk about correct coding, and particularly this slide talks about diagnosis coding. So we want to make sure that when we're talking about the diagnosis coding, that we are reporting everything that is relevant and affects the treatment or the plan of treatment for that patient on that particular date of service or that particular counter. So different payers reimburse differently. So you want to make sure that you're accurately coding and reporting those services to the most accurate and specific levels. I don't know how many of you are aware, but within the last 2 or 3 years, the ICD-10 diagnosis codes has expanded tremendously. I think they added 70 or 75,000 additional diagnosis codes. And a lot of those are very, very specific diagnosis codes. Kind of my rule of thumb when it comes to diagnosis coding is, if you've got a diagnosis code that ends in the number 9, that's still kind of a generic, general diagnosis code. So I would try to avoid reporting a diagnosis code that ends with a 9, because 9 times out of 10, there's going to be a more specific diagnosis code that you can report. And it just provides that payer more specificity as to what's really happening with that patient. So that's what you want to do. You want to tell that payer the true health of that patient. And the other thing that I like to tell people is, what's on that claim, you're telling that payer, whether it's Medicare or Medicaid, or it's a commercial, or it's United, whoever it is, that claim is telling the story of that patient from the minute that patient hits your door to the minute that they leave. And if you think in terms of your CPT and your HCPCS codes, tell the payer what you did, what happened, how did you take care of that patient when they were there? And then the diagnosis codes tell them why you did what you did. So if you're ordering labs, or if you're ordering test, any kind of diagnostic test or anything, whatever you're doing, that diagnosis code needs to be able to support why you're doing what you're doing. And the best example that I can give on this particular issue is, many years ago, I was doing a physical therapy audit, and I was looking through all of their SOAP notes and all of their encounter notes, and was looking at their claims. The patient was coming in 2 or 3 times a week for physical therapy, and the only diagnosis code that they had on that claim was a diagnosis code for a urinary tract infection. And they were getting denied, and they couldn't understand why they were getting denied. So the diagnosis code has to be tied to all of the services or the procedures that you are performing and are providing. There has to be a link there. So keeping that in mind as you make your selections for your diagnosis codes, as well as your E&M levels, just making sure that they tie together. That's the main thing. And making sure that we're telling that payer truly, the severity or the acuity of that patient while they're there and they're receiving the services. Okay, so a little bit on reimbursement. We talked a little bit earlier about how most RHCs are reimbursed on the AIR rate, which is an all-inclusive rate. It's a bundled payment per visit for your primary care and your preventive health care services. And those preventive services are your annual wellness visits and your IPPEs, your initial preventive physical exams. You'll receive full air payment on that. The patient will pay nothing. I will say on the preventive services, there are very specific documentation requirements between an annual wellness visit and your initial preventive physical exam. Medicare has really done a pretty good job of outlining what's required to meet the criteria for an annual wellness visit versus the documentation that's required and exams and everything that's required for an IPPE. So if you've got any kind of doubt as to, is this a routine E&M visit? Is it an annual wellness visit? Or is it an IPPE? There are fantastic resources and references from the CMS website that literally details it out line by line. So if there's any question there, I would recommend that you check that out. For other services, Medicare will pay approximately 80% of the air rate, and then the patient pays the remaining 20%. RHCs must report a modifier CG on one of those revenue codes, either the 0520 or the 0900 service line per day for the bundled service. And that tells that payer that that service line is subject to coinsurance and deductibles. Okay, I just wanted to put this up to show you guys kind of where we are today with the RHC air payment rate. So you can see it's gone up a little. It will continue to go up, but right now in 2023, we're sitting at $126. That is based on a qualifying visit qualifying visit in Medicare's eye. So these are just the rates and what they're going to look like. You know, by the year 2028, we're going to be sitting at about $190. Okay, incident 2. So a lot of times this is referred to as it's a service that has no charge or it's included in the RHC bill. These are services that are typically commonly furnished in the physician office or clinic. It's furnished under the physician's direct supervision, and it can be furnished by a member of the RHC. Also considered to be incident to are drugs and biologicals that are not usually self-administered. And some of those Medicare covered preventive drugs like the influenza and the pneumococcal. Bandages, gauze, oxygen, other supplies, or assistance by personnel such as nurse, MAs, or anyone acting under the supervision of the physician. Incident 2 services are considered covered and paid under the RHC. They must be bundled, though, with that RHC encounter. The services that do not occur on the same date as the encounter can be bundled if they occur 30 days either before or after a visit. The effect on the payment is there's an increase in the charge, therefore, in the coinsurance. And then the cost of these services are included in the cost report, but are not separately payable on the claims. So doesn't mean when it talks about direct supervision, that doesn't mean that the physician must be present in the same room. That just means the physician must be in the RHC and readily or immediately available if need be. So examples of non-encounters, and these are examples that Medicare has deemed that they do not warrant medical necessity. So injections, someone's coming in for, I don't know, some sort of injection. Your nurse is going to do that injection and never even see the physician. Suture removals, dressing changes, prescription services, and then blood pressure monitoring. You know, if you've got somebody coming in says, I just need my blood pressure checked, that doesn't typically warrant any kind of medical necessity. Okay, so qualifying visits. RHCs are to report one service line per encounter visit with a revenue code of 520 and a qualifying medical visit, or 0900, which is a qualifying behavioral health visit from the RHC qualifying visit list. So payment and any applicable coinsurance or deductible will be based on that qualifying medical visit line. On the bottom of this slide, I have attached a link that you can go to that will show you. It will open up a document from CMS that has all of the qualifying visit list, CPT/HCPC codes on that list. I have provided in the next slide, this is just a snippet. I mean, it truly is just one little snippet of the qualifying visit list codes that are published out there on the CMS website. So this is what it's going to look like for you. I think the document may be, I don't know, 10 or 11 pages long, but it's good information. Okay, so when we start talking about getting into the nuts and bolts of the billing, so Medicare does not adjudicate your RHC claims based on the total charge amount. They adjudicate that claim based on the qualifying visit line, service line. So the qualifying visit line should be the sum of all of those charges minus any preventive services. And I know this is a lot to take in, but I've got some examples that we're going to kind of talk through in just a minute or two. So total charges are going to be reported as allowed charges on the remits, but the patient coinsurance and deductible amounts are based on that qualifying visit line. So everything is driven, adjudicated off of that qualifying visit service line on your claim. So again, just down here, the RHC's services, they're going to be submitted on a UB04 claim. It's going to be a type of bill 0711 for the original. Your services must be reported using the appropriate revenue code from that list that we looked at a little bit earlier. And then all claims must have a qualifying visit denoted with the CG modifier. And then incident to services must be reported on the claim, but bundled with the qualifying visit. And we'll kind of talk about what that looks like. So beginning October of 2016, RHCs need to add that modifier CG to the line with all of the charges subject to coinsurance and deductible. If only preventive services are furnished during the visit, the RHC should report modifier CG with the preventive HCPC code that represents the primary reason for that medically necessary face-to-face visit and bundled charges. Okay. Caroline, are you on slide 25? I just want to make sure
Yeah, I
everybody.
am now incident to services billing incorrect, or the CG modifier example.
The CG modifier example.
Okay, yeah.
Sorry. Yeah. I'm flipping through mine and I'm just assuming you're coming right along with me. So I
I'm
apologize
trying
for that. Sorry about that. Okay. So this is an example of what your claim form might look like. It's just a snippet of the service lines. It doesn't include the header or the payer or anything like that. But it's just a snippet of the service charge lines. So this is an established patient that was seen, and a qualifying visit of a level 3 established patient is generated for $100. The applicable coinsurance and or deductible is calculated using the $100. So the CG modifier is going to go on this qualifying visit line right here. I'm using my pointer like you guys can see. And I see a typo that should be 99213. So that's what the CG modifier example looks like. Okay, the next one. Then this one that says incident to services billing incorrect. Is that the one you're on?
Yes.
Okay, sorry. Okay, so there's a lot going on with this slide. We can tell that the patient came in. It's An established patient, a level 3, has been assigned. This patient also got Rocephin. He got a Rocephin injection. So your qualifying visit line is going to be your 99213 with the CG modifier. You can tell that the $30 for the Rocephin and the $20 for the injection administration code have already been bundled with the 99213, which brings that up to $150. But then you'll see on the second and third line, those have been detailed out with those individual charges of $20 and $30. So what's happening is this claim, the charges on these claims are being inflated because the injection and the administration charges from the detail lines are duplicated and built in to that 99213. So this is an incorrect way to submit a claim. Just want to make sure everybody understands, you know, these are duplicated charges. So this claim and the charges are overinflated. So if you go to the next one, this one should say incident to services alternative billing correct. So what we would do is we would take that same office visit for that established patient, that level 3, that 99213, which is your qualifying visit code with the CG modifier. We would add the $20 and the $30 for the Rocephin and the injection administration. We would roll those up into the 99213, which brings it to $150.02 because the detailed lines below it are reported as a penny a piece. So what you've done is, this is really the most correct way and accurate way. You're not overinflating your charges. You're providing the detail, but you are accurately reporting the charges as they should be applied. I hope that makes sense to everyone. So these service detail lines, they can be reported with a penny, which kind of helps eliminate, you know, any type of artificial or inflation on the revenues and your AR adjustments and that kind of stuff. And then that line, that 99213 with the CG modifier, that's going to be used to calculate the total charges for your coinsurance and your deductible calculations. Okay, next slide. Bundled services. So let's say you've got bundled services, but different dates of service. So services provided on a different day as a billable visit may be included in the charges if furnished in a medically appropriate time frame. So you're not going to span dates on your admit from and admit through dates. This is going to cause any other claim submitted within those dates to reject. So you're just going to have one admit from, admit through date. We'll show, the next slide will show you what that looks like. So let's say that this particular patient was getting 4 weekly allergy injections at $20 a piece. They were provided in July of 2021. They had no corresponding E&M visit on the day that, you know, for each one of these 4. But then let's say in August, that patient came in on August the 12th and had an office visit. So what you're going to do, because when this patient came in, we're getting these 4 allergy injections and they had no qualifying visit code or visit service line, those could not be reported just by themselves. It has to be reported with a qualifying visit code, which is going to be something like a 99213. So what you're going to do is you're going to combine those 4 allergy injections with that office visit that occurred on August the 12th. And you're going to report the E&M code with the CG modifier, and you're also going to report those allergy injections that that patient got. And you're going to add them together. You're going to bundle them together, even though there's different dates of service. Those allergy injections cannot stand alone, right? Because there was no qualifying visit as they were coming in for those allergy injections. So this is what that claim would look like for this particular scenario. And then Medicare, again, is going to use that qualifying visit code, that 99213, to determine the total charge and calculate the coinsurance. I know we're getting low on time here. I'm going to have to start talking a little faster. So the next slide is behavioral health qualified visits. These are the CPT codes and just the short description from the CPT manual as to what is allowed within an RHC for behavioral health visits. And the next slide is an example of what that's going to look like on your claim form. You're going to report that with a revenue code 090, and then the 90832 with your CG modifier again, and your total charge. And I'm just going to tell you guys, my computer acts like it's going to try to reboot. I hope it doesn't. I hope it gives me the option to tell it no. Okay, so what happens if you've got minor surgical procedures? So you're going to report those as encounters. So follow-up visits for dressing changes or suture removals only can be billed as encounters if there's a medically necessary documented reason. So remember, dressing changes and suture removals are on that list from Medicare that they've identified as non-medically necessary encounters. So it's going to take some very robust documentation to support dressing changes or suture removals. If an office visit is performed during the same visit as a minor surgical procedure, the clinic will only have one encounter to bill. These should be bundled and submitted on as one line item. And I have an example of this on our next slide. Surgical procedures furnished in an RHC by an RHC practitioner are considered RHC services. So if we go to the next slide, this is what a procedure is going to look like. So if the patient comes in for a wound repair scheduled encounter for wound repair, this top is what it's going to look like. You're going to report that CPT code for the wound repair, that CG modifier, and your charge. If that patient comes in and has the wound repair or has an additional office visit on that same day, again, you're going to report both that office visit and then that wound repair with your dates of service. And again, we're going to list that office visit as your qualifying visit. And detail out that wound repair is a penny charge because you're going to include that wound repair. You're going to bundle that up into your procedure or your visit. So just having a good understanding if they come in and they've got, what's considered a bundled encounter within an office visit. Okay, your influenza and your pneumococcal vaccines, those are going to, again, these are going to be paid at 100% of the reasonable cost through the cost report. You really shouldn't be billing these on, if that's all they're there for, you should not be billing these on a claim. It's going to be reflected in your cost report. These are the only injections that are payable outside of an RHC claim, and then the beneficiary coinsurance and deductible are waived for these vaccines. Okay, multiple encounters. So on the same day, do you use modifier 25 or do you use modifier 59? So modifier 59 typically indicates that there's been a separate condition on the same treatment date that are not related. So this is used only if a subsequent illness or injury on the same day as another visit. So modifier 25 and on RHC is interchangeable with modifier 59. Modifier 25 is different in the RHC, and then it's only on the subsequent service line of the UB04 claim form. And I think I have an example on the next slide. I will say really quickly though, before I forget about it, that modifier 25 is in the RHC world, it's not really used to distinguish an E&M service from a procedure. A lot of times we see modifier 25 if somebody comes in and they have an E&M visit, but then they did some sort of diagnostic test, we will see that modifier 25 on the E&M, but that does not apply in the RHC world. So here's an example of a subsequent visit. I hope you're with me, Caroline. I'm on 36. So you can see that you've got an office visit, established level 3 office visit, which is the 99213 with the CG modifier. And then let's say something happened where that patient came in that morning and had that level 3 visit. And then later in the day, I fell and got this laceration, and I come back to the clinic for some sort of laceration repair. You're going to put those on the same claim. And again, you're going to bundle your charges for that laceration repair up into your office visit level. You're going to report them separately, but you're going to report that laceration repair with a penny assignment. And then you're going to put that 59 modifier on the laceration. That 59 modifier is always going to go on that subsequent service line. So not the initial, but on the subsequent service line. I've got 3 minutes and I think I've got 3 slides left. Well, woman exams. So we all know that Medicare doesn't pay for these CPT codes 99381 through 99387. An annual or subsequent wellness visit is reported for the exam. And then if you do any kind of breast or pelvic exam and or the pap smear. So in the RHC world, you're going to report annual or subsequent wellness visit. If you do a breast or pelvic exam, you're going to report this G0101. And then if you do a pap smear, you're going to report this Q0091. So just understanding that if you report these CPT codes, your Medicare will never pay for those. And then also, you know, during preventive services, the patients are not responsible for any kind of co-insurance or deductible. Oh, I made it. Look here. This is just references that we have provided for your review and references. They're great resources that are out there, and highly recommend that if you're looking for guidance or have specific questions, all of these references will be able to help address and answer any of those questions. And then that's it. I know that I have a couple of questions specific to the behavioral health provider piece, and I will get some answers on those and share that back with you, Caleb, if that's okay. If then you want to go ahead and share those or forward those on.
Yeah, that'd be just fine.
Were there any other questions that I missed or maybe didn't see?
Not to my knowledge. Let's see here. There are a couple are just coming in the chat here. I'm gonna go ahead and launch post polling before we have to jump off.
Okay.
Fill it out as your leisure. But yeah, there's a couple more questions. It looks like yep, a copy of the presentation will be made available. It has to go through a little bit of process, but it'll be put on our website. And another question that says, what determines when you bill 0.01 and when you bill a higher dollar amount?
Oh, okay. Okay. Gotcha. Okay. Sorry, I was going to ask you, can I grab those questions from the chat, or can you email those questions to me?
Yep, I can email
It's the
them.
easiest way, I guess.
Yep, I can email them to you.
Okay, perfect. That way I can address all of them and make sure I don't miss anything.
I just took a screen grab of them, Stacy.
Oh, thank you,
if-
Caroline.
That way
Thank you.
Caleb doesn't have to email them.
Okay, thank you.
Yeah, you're good.
Very good questions. I know that was a lot to get through. I think on the higher dollar amount on the 0.01, that's an internal decision that you got internally your facility or your leadership needs to make the determination of what they want that to look like. I would just caution again on, duplicating or overinflating those charges.
Okay, well, thank you everyone for your participation on today's call. And as you can see, Caleb did put the poll up, so if you would please answer the polling questions. And I hope everyone has a wonderful day.
Thank you all. Appreciate it.
Thank you all. Bye-bye.
Thank you, everybody.
Bye-bye.